My name is Thomas Patterson, and for 10 years I worked as supply officer for Millfield Psychiatric Hospital. The position required comprehensive inventory management of medical supplies, pharmaceuticals, and equipment throughout the facility's multiple wings and treatment areas. My responsibilities included quarterly inventory of all medication storage areas, including the basement pharmacy that had been sealed since 1987, when drug storage was centralized to the main pharmacy on the first floor. The basement area remained locked and unused, but regulations required periodic inspection to ensure no controlled substances remained unsecured. The basement pharmacy consisted of 3 rooms: main storage area with floor-to-ceiling cabinets, a preparation room with work surfaces and measuring equipment, and a small office space with filing cabinets and record-keeping materials. Standard institutional pharmaceutical storage that had served the hospital's needs for over 30 years. For 9 years, my quarterly inspections found the basement pharmacy exactly as expected. Empty cabinets, dust-covered work surfaces, and filing cabinets containing obsolete records from the facility's earlier operational periods. Nothing requiring attention beyond basic security verification and documentation that the area remained properly secured. But on November 15, 2020, during my routine quarterly inspection, I discovered something that challenged my understanding of both pharmaceutical storage and the temporal limitations of medication management. The main storage cabinets, which had been empty for over 30 years, were fully stocked with medications. Not old pharmaceuticals that had been forgotten during the 1987 closure, but fresh medications in current packaging with labels that appeared to have been recently prepared. The vials were at room temperature rather than showing the cold storage effects that would indicate long-term abandonment. I examined the medication labels carefully. Each vial bore handwritten identification in blue ink that appeared consistent with 1950s pharmaceutical labeling practices, but the medications listed were modern drugs that hadn't been available during that historical period. Fluoxetine, 20 milligrams. Patient, Dr. Williams, R. Daily as directed. Lorazepam, 1 milligrams. Patient, Thompson, Sarah, PRN anxiety. Risperidone, 2 milligrams. Patient, Martinez, David, twice daily with meals. The medications were current psychiatric drugs prescribed for individuals whose names matched current Millfield staff members. Dr. Williams was our chief psychiatrist. Sarah Thompson worked in nursing administration, and David Martinez was a senior orderly. But the handwriting and label format suggested the prescriptions had been prepared decades earlier using pharmaceutical practices that predated the modern medications being dispensed. I checked the vial's contents. The medications appeared fresh, properly preserved, and maintained at appropriate temperatures despite being stored in an unheated basement area that had been sealed for over 30 years. Most disturbing was finding a vial labeled with my own name, Patterson Thomas, sertraline 50 milligrams, daily for anxiety management. I wasn't currently taking sertraline, hadn't been prescribed anxiety medication, and had no psychiatric treatment history that would require pharmaceutical intervention. But the vial contained what appeared to be a 30-day supply of medication specifically prepared for my use. I contacted Dr. Williams requesting explanation for the medications I had discovered in the sealed basement pharmacy. Thomas, there are no active prescriptions stored in the basement, Dr. Williams replied after checking the pharmaceutical records. All medications are managed through the main pharmacy. The basement has been empty for decades. I brought Dr. Williams to examine the discovered medications, showing him the fully stocked cabinets and the prescription labels bearing staff members' names. But when we opened the storage cabinets together, they were empty. No medications, no pharmaceutical supplies, no evidence of the fully stocked inventory I had documented just hours earlier. Thomas, these cabinets are empty, just as they should be, Dr. Williams observed. Are you sure you saw medications here? I was certain about what I had observed. Dozens of medication vials, properly labeled and apparently freshly prepared, but the physical evidence had vanished, leaving only empty storage. Cabinets that showed no signs of recent pharmaceutical activity. Over the following weeks, I began experiencing symptoms that corresponded to the conditions suggested by the medication labels I had discovered. Increased anxiety, sleep disturbances, and stress-related issues that might benefit from the sertraline prescription I had found with my name. I scheduled an appointment with Dr. Williams for anxiety management, explaining that work-related stress was affecting my ability to function effectively. "Thomas, I think sertraline would be appropriate for your symptoms," Dr. Williams recommended after comprehensive evaluation. 50 milligrams daily should help with anxiety management. The prescription exactly matched the medication I had found in the basement pharmacy. Same drug, same dosage, same treatment regimen that had been prepared with my name weeks before I had developed the symptoms that required pharmaceutical intervention. I realized that the basement pharmacy was somehow providing advanced prescriptions for staff members, preparing medications for conditions that hadn't yet developed, but that would require treatment in the near future. I began paying closer attention to my colleagues' health and behavior, comparing their conditions to the medications I had discovered in the basement storage cabinets. Dr. Williams began showing signs of depression that would benefit from fluoxetine treatment. Sarah Thompson developed anxiety symptoms that corresponded to lorazepam prescriptions. David Martinez exhibited behavioral changes that suggested need for risperidone therapy. Each staff member eventually received prescriptions that matched the medications I had found in the basement pharmacy, though none of them had been experiencing symptoms at the time the advanced prescriptions were apparently prepared. On December 20th, I returned to the basement pharmacy for another inspection, hoping to understand how the advanced prescription system operated and whether additional medications had been prepared for future staff needs. The storage cabinets were fully stocked again, containing medications for additional staff members and extended supplies for individuals who were already receiving treatment. But I also found something that made my hands shake, a vial labeled with my name and dated for the following day. Patterson, Thomas. Haloperidol 5 mg. December 21st, 2020. For acute psychiatric episode, haloperidol was an antipsychotic medication used for severe mental health crises. The prescription suggested I would experience psychiatric symptoms requiring immediate medical intervention within 24 hours. I left Millfield that afternoon, submitting immediate resignation, citing personal health concerns that made continued employment inadvisable. But I kept detailed documentation of the basement pharmacy phenomenon, including photographs of the medication, labels and prescription information that had somehow predicted future pharmaceutical needs for hospital staff members. Sometimes I wonder whether I successfully avoided the acute psychiatric episode that had been predicted by the advanced prescription system, or whether my resignation was simply part of the behavioral changes that had been anticipated by medications prepared before symptoms developed. Some pharmaceutical systems, I learned, operate according to principles that transcend normal prescription timing, preparing medications for conditions that haven't yet manifested, but that will require treatment by professionals who understand their responsibilities to both institutional needs and their own psychological well-being. My name is Jennifer Martinez, and for 14 years I worked as a registered nurse at Westbrook State Hospital. During my tenure, I became familiar with every area of the facility, including the various wings and wards that had been closed or modified as the hospital's operational needs changed over the decades. Ward 9 had been decommissioned in 1985 following budget cuts that reduced the hospital's patient capacity. The ward's entrance was secured with heavy chains and marked with authorized personnel-only signs that discouraged staff from entering the abandoned area. For 13 years, I had no reason to visit Ward 9. The area was sealed, unused and irrelevant to current hospital operations. My duties focused on active patient care areas where my nursing skills were needed for ongoing medical treatment and psychiatric care. But on September 8, 2019, while responding to a medical emergency on the adjacent Ward 8, I inadvertently entered Ward 9 through what I thought was a supply closet door that would provide faster access to emergency equipment. Instead of finding a storage area, I discovered something that challenged my understanding of both hospital operations and the fundamental principles of patient care management. Ward 9 was fully operational, not abandoned or decommissioned, but actively functioning as a complete medical unit with patients, equipment, and all the infrastructure necessary for comprehensive healthcare delivery. The corridor was well lit, properly maintained, and showed clear signs of ongoing use by medical personnel. I walked through the ward carefully, trying to understand how an area that had been officially closed for over 30 years was continuing to provide patient care services. The patient rooms were occupied by individuals who appeared to be receiving appropriate medical treatment. Each room contained standard hospital beds, monitoring equipment, and intravenous lines that suggested active medical intervention for serious health conditions. But the patients were unlike any I had encountered during my nursing career. They lay completely still, eyes closed, showing no signs of movement or awareness, despite being connected to various medical devices that indicated ongoing physiological monitoring. The IV lines and monitoring cables were connected to the patients, but they didn't lead to any visible supply sources or monitoring stations. The tubing simply ended at the room walls, as if the medical equipment were functioning without connection to utility systems or pharmaceutical supplies. I approached the nearest patient room to examine the medical setup more closely. The patient was an elderly man, approximately 70 years old, connected to IV tubing and cardiac monitoring leads, but the monitoring equipment showed no readings, and the IV bag was empty with no connection to medication supplies. Yet the patient appeared stable, breathing regularly, and showing vital signs that suggested ongoing medical support, despite the absence of functional medical equipment. I checked the patient's medical chart, hoping to understand his condition and treatment requirements. The chart was comprehensive and detailed, but the dates troubled me deeply. Admission date, March 15th, 1971. Latest entries, March 1975. The chart documented 4 years of medical care, but the dates were from nearly 50 years in the past. Yet the entries appeared fresh, written in blue ink that showed no signs of aging or deterioration. I examined additional patient charts throughout. Ward 9. All showed similar date patterns, admissions from the 1960s and 1970s, ongoing treatment documentation that spanned years or decades, but written in ink that appeared recently applied. Patient Morrison. John, admitted on June 3, 1969. Chronic psychiatric condition requiring long-term medical support. Patient Davis. Margaret, admitted on August 12, 1973. Complex medical needs, stable condition, continued monitoring. Patient Williams. Robert, admitted on January 8, 1967. Long-term care, family notified of ongoing treatment. Each chart documented comprehensive medical care for patients who had been receiving treatment for decades longer than normal hospital stays. In a ward that had been officially closed since 1985, I walked through the entire ward, counting 24 patients in various rooms, all receiving medical care that appeared to be ongoing since the late 1960s and early 1970s. But none of the patients showed signs of aging that would correspond to 50 years of continuous medical treatment. The nursing station was staffed by individuals I didn't recognize, nurses in uniforms that appeared to be from earlier decades, working with medical equipment that looked functional but obsolete compared to current hospital technology. "Excuse me." I approached one of the nurses. "I'm Jennifer Martinez from Ward 8. Can you tell me about your patients?" The nurse looked up from her documentation with a professional smile. "Good evening, Nurse Martinez. We're providing long-term care for patients who require extended medical support. Standard procedures, nothing unusual. How long have these patients been here?" "Since their admissions. Some have been with us for several years, others for decades. We maintain their care according to their ongoing medical needs." "But Ward 9 was closed in 1985. How are you continuing operations?" The nurse looked confused. "Ward 9 has never been closed. We've been providing continuous patient care since the ward opened. No interruptions in service." I tried to explain that Ward 9 had been decommissioned, that the area was supposed to be sealed and unused, and that current hospital records showed no patients assigned to this ward. But the nursing staff insisted that operations had continued normally, that patients were receiving appropriate care, and that no administrative changes had affected their medical services. I decided to return to Ward 8 and report my discoveries to the hospital administration. But when I tried to leave Ward 9 through the door I had entered, I found something that made my blood run cold. The door was gone, not locked or sealed, but completely absent. The wall where the door had been located was covered with fresh concrete, still damp to the touch, as if the entrance had been permanently sealed within the past few minutes. I searched Ward 9 for alternate exits, but found only solid walls where doorways should have provided access to adjacent hospital areas. The ward had become completely isolated from the rest of the hospital, with no apparent means of entry or exit. "How do staff members enter and leave Ward 9? I asked the nursing supervisor. "We don't leave," she replied simply. "Our patients require continuous care. We live here, work here, and provide medical services 24 hours a day. Don't you have days off? Time away from the hospital. Our patients need us. Long-term care requires dedication that extends beyond normal work schedules." I realized that the nursing staff in Ward 9 weren't following standard employment practices. They were providing continuous medical care without breaks, without time off, and without connection to the hospital's normal administrative structure. But the patients were receiving excellent care. Their charts documented detailed medical monitoring, appropriate interventions, and professional nursing services that maintained their health despite the unusual circumstances of their extended hospitalizations. I found an empty room in Ward 9 and decided to rest while trying to understand my situation. The bed was comfortable, the room was clean, and the environment was conducive to recovery from the shock of discovering an impossible medical facility. When I woke, I found a fresh uniform laid out for me, nursing attire appropriate for Ward 9's medical services. And on the bedside table was a patient assignment list with my name at the top, showing responsibility for 12 patients requiring long-term medical care. The assignment list was dated September 8, 2019, but it also showed my start date as a Ward 9 nurse, September 8, 1979, exactly 40 years earlier. I've been working in Ward 9 for what feels like several months now, though the calendar on the nursing station wall doesn't seem to change dates in any consistent pattern. Sometimes it shows 1975, sometimes 1983, occasionally 2019. But the patients continue receiving excellent medical care, and I've found that long-term nursing provides professional satisfaction that exceeds normal hospital employment. The work is meaningful, the patients are stable, and the nursing staff works together with dedication that transcends typical institutional boundaries. Sometimes I wonder whether other hospital staff have discovered Ward 9, and whether they've also found that some patient care responsibilities require commitment that extends beyond normal employment limitations. Some medical facilities, I've learned, operate according to principles that transcend normal administrative boundaries, providing continuous care for patients who need services that exceed the temporal constraints of standard hospital operations. My name is Robert Williams, and for 9 years I worked as head of security for Riverside Psychiatric Hospital. The position required comprehensive knowledge of emergency procedures, including fire drills, evacuation protocols, and patient safety measures that ensured appropriate response to crisis situations. Monthly fire drills were mandatory under state regulations. Each drill required complete evacuation of designated hospital areas, documentation of evacuation times, and assessment of staff performance during emergency procedures. The drills were scheduled, supervised, and evaluated to maintain compliance with safety standards. On March 22, 2020, I conducted a routine fire drill for the East Wing, which housed 36 patients in secure psychiatric care. The drill began at 2 p.m. with activation of fire alarms and announcement of evacuation, procedures over the hospital's public address, system standard evacuation protocol required, orderlies to assist patients in leaving their rooms, escort them through designated evacuation routes, and gather in the hospital courtyard for attendance verification and safety briefing. The East Wing evacuation proceeded smoothly. Patients responded appropriately to evacuation instructions, orderlies provided necessary assistance, and everyone assembled in the courtyard within the required time frame. The drill demonstrated excellent staff coordination and patient cooperation. I documented the evacuation with standard photography, wide shots of patients and staff assembled in the courtyard, close-ups of identification procedures, and overall views that showed successful completion of evacuation protocols. The photos clearly showed all 36 East Wing patients standing in the courtyard with appropriate staff supervision. Each patient was visible, properly accounted for, and participating in the safety briefing that concluded the evacuation drill. Attendance verification confirmed complete evacuation, all patients present in the courtyard, all staff members accounted for, and no individuals remaining in the East Wing during the simulated emergency. The drill concluded at 2:45 p.m. with systematic return of patients to their rooms. Orderlies escorted small groups back through the hospital corridors, ensuring everyone returned safely to their assigned areas. But when I reviewed the evacuation documentation that evening, I discovered something that challenged my understanding of both the drill results and the basic principles of patient census management. According to the nursing records, all 36 East Wing patients had remained in their rooms throughout the afternoon. The patient census showed continuous occupancy, with no notation of evacuation activities or temporary relocation to the courtyard. I checked the afternoon nursing logs. Every patient was documented as present in their assigned rooms during the 2 to 3 p.m. time frame when the evacuation drill had occurred. Patient Morrison, room 301, resting quietly, no issues. Patient Morgan, room 304, reading. Declined activity participation, patient Davis, room 317, sleeping. Vital signs stable. The nursing documentation indicated that all patients had remained in the East Wing during the exact time period when I had photographed them assembled in the courtyard for fire drill procedures. Showed the evacuation photographs to Charge Nurse Thompson. Can you explain how all East Wing patients are documented as being in their rooms during the fire drill when my photos show them in the courtyard? Thompson examined the photographs carefully. These are definitely our patients, and they're clearly standing in the courtyard. But our logs show everyone remained in their rooms. This doesn't make sense. I reviewed the photographs again, counting patients and comparing faces to the East Wing census roster. Every patient was accounted for in the courtyard photos, but every patient was also documented as remaining in their rooms according to nursing records. Who conducted the evacuation? Thompson asked. Which orderlies led the patients to the courtyard? I checked my drill documentation. The evacuation had been led by Senior Orderly Martinez, assisted by Orderlies Johnson and Peterson. Standard staffing for East Wing emergency procedures. But when I contacted Martinez about the evacuation, he had no memory of participating in any fire drill that day. Mr. Williams? I was off duty on March 22nd, Martinez said. Personal leave day. I wasn't at the hospital during afternoon hours. I checked the staffing records. Martinez was indeed scheduled for personal leave on March 22nd. Johnson had called in sick, and Peterson was assigned to the West Wing that afternoon. None of the orderlies I had documented as leading the evacuation had actually been present in the East Wing during the fire drill, but my photographs clearly showed patients being supervised by orderlies in proper uniforms who were conducting professional evacuation procedures according to established protocols. I examined the evacuation photos more closely, trying to identify the staff members who had assisted with patient evacuation. The orderlies were visible in several shots, but their faces were somehow indistinct. Professional appearance, appropriate uniforms, but features that remained unclear despite good photographic quality. I showed the photos to other hospital staff, asking if they could identify the orderlies who had participated in the evacuation drill. I can see there are orderlies in the photos, observed Nurse Patterson, but I can't make out who they are. Their faces aren't clear. They're wearing proper uniforms, noted Supervisor Davis, but I don't recognize any of them as current staff members. The evacuation had apparently been conducted by orderlies who weren't on duty that day, weren't current employees, or weren't identifiable, despite clear photographic documentation of their professional evacuation assistance. I attempted to reconcile the conflicting documentation. Photographs showing successful patient evacuation versus nursing logs indicating continuous room occupancy during the same time period. Both sets of evidence were authentic. The photographs were taken with hospital equipment during the scheduled drill time. The nursing logs were completed by credentialed staff following standard documentation procedures. But the evidence contradicted fundamental principles of patient location. Individuals couldn't simultaneously be in their rooms and assembled in the courtyard for evacuation. Procedures. I submitted my fire drill report noting the successful evacuation while acknowledging documentation discrepancies that required administrative review. But I included all photographic evidence showing that East Wing patients had participated appropriately in emergency procedures. 6 months later, during the next scheduled fire drill for the East Wing, I paid closer attention to the orderlies who led the evacuation procedures. Again, the evacuation proceeded smoothly with professional staff supervision. Again, patients cooperated fully and assembled appropriately in the courtyard. Again, my photographs documented successful completion of emergency protocols. But again, the orderlies who conducted the evacuation weren't identifiable as current hospital employees. And again, nursing logs showed all patients remaining in their rooms throughout the drill period. I realized that East Wing fire drills were being conducted by staff members who existed specifically for emergency procedures, ensuring patient safety during crisis situations regardless of normal staffing availability or administrative scheduling. The evacuation procedures worked perfectly, protecting patients through professional emergency management that transcended typical employment limitations and duty roster constraints. Some emergency procedures, I learned, are conducted by staff members whose dedication to patient safety extends beyond normal employment boundaries, ensuring appropriate crisis response regardless of administrative scheduling or documentation requirements. My name is Susan Morgan, and for 12 years I worked as a psychiatric nurse at Millbrook State Hospital. One of my responsibilities involved managing seclusion room documentation, the detailed reports required when patients needed to be placed in secured isolation for safety reasons or behavioral intervention. Seclusion procedures required comprehensive paperwork to satisfy both regulatory requirements and legal protection for hospital staff. Each incident needed detailed documentation, patient behavior that necessitated seclusion, staff members involved in the intervention, duration of isolation, and medical monitoring throughout the seclusion period. The reports were critical for maintaining appropriate patient care standards and protecting the hospital from liability issues related to restraint procedures. State inspectors reviewed seclusion documentation regularly, looking for patterns of inappropriate use or inadequate medical supervision. For 11 years, seclusion reports followed predictable patterns. Documented incidents involved patients with established behavioral issues, staff members who were trained in appropriate intervention techniques, and outcomes that reflected professional psychiatric care management. But in August 2020, I began finding seclusion reports in my files that didn't correspond to any incidents I could recall or verify through hospital records. The reports described patients I didn't recognize engaging in violent behaviors that resulted in injuries to staff members I worked with daily. But neither the patients nor the incidents appeared in our current census or incident logs. Seclusion report, 2/2/20-847, patient Dean, Miguel, violent outburst during medication administration. Struck Nurse Thompson in face, causing facial laceration requiring medical treatment. Patient placed in seclusion room for 6 hours pending psychiatric evaluation. I knew every patient in our ward, but Miguel Dean wasn't among them. We had no patient by that name, no admission records for a Dean, and no incident reports involving facial injuries to Nurse Thompson. But when I checked with Thompson the following day, I found something that troubled me deeply. She had a facial laceration that appeared consistent with the injury described in the mysterious seclusion report. "Sarah, what happened to your face?" I asked, examining the cut on her cheek. "I'm not sure," Thompson replied. "I woke up this morning with this scratch. Must have done it in my sleep somehow." The injury matched the seclusion report's description exactly. Facial laceration that would require medical attention, positioned exactly where a striking motion would cause contact. I found additional seclusion reports that described incidents involving other staff members and patients who weren't present in our facility. Patient Martinez, Elena, aggressive behavior during room check. Pushed orderly Williams downstairs, causing back injury and bruised ribs. Patient Davis, Robert, violent episode during group therapy. Threw chair at Nurse Patterson, striking left shoulder and causing muscle strain. Each report described injuries to current staff members caused by patients who didn't exist in our system. But over the following days, the described staff injuries began manifesting in the individuals named in the reports. Orderly Williams developed back pain and reported feeling like he had fallen downstairs, though he couldn't recall any specific incident. Nurse Patterson complained of left shoulder pain and muscle strain consistent with being struck by a thrown object. The seclusion reports were somehow predicting injuries that staff members would sustain, though the reported incidents weren't occurring through normal patient interactions. I attempted to trace the origin of the mysterious seclusion reports, checking our documentation procedures and administrative systems for any process that might generate reports about non-existent patients and incidents. No, administrative explanations existed for the appearance of detailed seclusion documentation about patients who weren't present in our facility and incidents that weren't occurring through normal hospital operations. But the reports continued appearing in my files, always describing violent patient behaviors that resulted in specific injuries to identifiable staff members. Patient Thompson. James. Physical aggression during evening rounds. Bit security guard Dean on left hand, causing puncture wounds requiring tetanus treatment. Patient Wilson, Catherine. Combative behavior during medication distribution. Scratched Nurse Anderson's arms with fingernails, causing multiple superficial lacerations. Each report was professionally written, properly formatted, and consistent with legitimate seclusion documentation. But they described interactions with patients who didn't exist and predicted injuries that staff members would develop without apparent cause. Security guard. Dean developed infected bite marks on his left hand within days of the seclusion, report that predicted his injury. Nurse Anderson noticed scratch marks on her arms that appeared overnight, matching the description in her predicted seclusion report. By September, I was filing seclusion reports for over 20 fictional patients who were apparently causing real injuries to actual staff members through incidents that weren't occurring in observable reality. The reports were becoming an administrative burden that exceeded normal seclusion documentation requirements. Filing cabinets were filling with reports about non-existent patients, and the volume of fictional documentation was interfering with legitimate patient care records. I decided to dispose of the mysterious seclusion reports by shredding them, treating them as administrative errors that didn't require permanent filing. But when I fed the reports through the office shredder, destroying dozens of documents about fictional patients and predicted staff injuries, something unexpected happened. The reports reappeared in my office locker the following morning. Not copies or reprints, but the original documents, intact and unshredded, filed neatly in my personal storage area with all the same detail and professional formatting they had contained before destruction. I tried shredding the reports again, using different equipment and disposing of the shredded material in separate trash containers to prevent any possibility of document recovery. But the reports continued reappearing in my locker, always overnight, always completely restored despite thorough destruction of the original paperwork. The seclusion reports apparently required permanent filing regardless of my attempts to eliminate them from our documentation system. By October, I realized that the reports were serving a purpose beyond normal administrative documentation. They were providing advance warning about injuries that staff members would sustain, allowing preparation for medical treatment and safety precautions that might minimize the severity of predicted incidents. When seclusion reports predicted specific injuries, I began alerting the affected staff members about potential safety risks and encouraging them to take precautions that might prevent the described incidents. Dean, be careful with your hands this week. Watch out for bite injuries or puncture wounds. Anderson, protect your arms during patient interactions. Be alert for scratching incidents. The warnings seemed to help. Staff members who were alerted about predicted injuries reported less severe symptoms than those described in the seclusion reports, though they still developed the basic injuries that had been documented in advance. On November 15th, I found a seclusion report that stopped me cold. Patient Morgan. Susan, aggressive behavior toward own documentation, attempted to destroy official hospital records. Patient requires psychiatric evaluation for reality testing and professional judgment concerns. The report described me as a patient engaging in inappropriate behavior related to seclusion documentation, suggesting that my attempts to destroy the mysterious reports constituted aggressive actions requiring medical intervention. I submitted my resignation the following week, citing personal health concerns that made continued work in psychiatric nursing inadvisable. But I kept copies of the seclusion reports as evidence of documentation systems that operate beyond normal administrative limitations, providing advance warning about staff injuries while ensuring that appropriate records exist for regulatory compliance regardless of normal filing procedures. Some documentation requirements, I learned, transcend normal administrative control, creating permanent records that serve purposes beyond standard hospital paperwork, while protecting staff members through advanced warning systems that operate independently of normal patient interactions. My name is David Martinez, and for 6 years I worked as an orderly at Riverside Psychiatric Hospital. My duties included patient transport, facility maintenance, and the various support services that kept the hospital running smoothly during all shifts and operational periods. Transport duties involved moving patients between hospital areas, escorting them to medical appointments, and coordinating with ambulance services when patients required transfer to other facilities for specialized care or discharge arrangements. Standard transport protocol required proper documentation, transfer orders from attending physicians, receiving facility confirmation, and ambulance scheduling that ensured appropriate medical supervision during patient movement. Every transfer needed multiple approvals and careful coordination to maintain patient safety and regulatory compliance. On March 8, 2021, during my normal morning duties, I received a transport request that initially seemed routine but gradually revealed aspects that challenged my understanding of both hospital procedures and patient transfer protocols. The request came from the charge nurse. Escort patient Thompson to the main entrance for 6 a.m. ambulance pickup. Standard early morning transfer that would transport the patient to a long-term care facility for continued psychiatric treatment. I collected the transport paperwork, physician orders, receiving facility acceptance, and ambulance service confirmation. All documentation appeared properly completed and authorized by appropriate medical staff. Patient Thompson was ready for transport when I arrived at his room. Well-groomed, cooperative, and packed with personal belongings that suggested planned discharge rather than emergency transfer. He seemed pleased about leaving the hospital and beginning the next phase of his treatment. "Good morning, Mr. Thompson. I'm David Martinez, and I'll be escorting you to your ambulance this morning." "Thank you, David," Thompson replied calmly. "I appreciate your professional assistance with this transfer." We walked through the hospital corridors at a comfortable pace, with Thompson showing no signs of anxiety or resistance about leaving familiar surroundings. He appeared mentally stable, appropriately oriented, and ready for the transition to different care arrangements. At the main entrance, an ambulance was waiting with 2 EMTs who greeted us professionally and confirmed Thompson's identity before beginning transfer procedures. "We're here for Thompson." "David," the senior EMT said, checking his clipboard. "Long-term care transfer to Millbrook facility." The EMTs loaded Thompson into the ambulance efficiently, secured his belongings, and completed their documentation according to standard medical transport protocols. Thompson settled into the ambulance quietly, expressing gratitude for the hospital's care and optimism about his continued treatment. I signed the transfer documentation, verifying that Thompson had been released to ambulance care in stable condition with appropriate belongings and medical records for the receiving facility. The ambulance departed at 6:15 a.m., carrying Thompson toward what I assumed was successful discharge and continuation of his psychiatric care in a more appropriate long-term setting. But when I returned to the nursing station to file the transfer paperwork, I encountered something that troubled me deeply. "Martinez, what transfer are you documenting?" asked Charge Nurse Wilson, examining the papers I was preparing to file. "Patient Thompson's discharge to Millbrook facility." 6 a.m. ambulance pickup. Wilson checked the patient census and scheduled transfers. "We don't have any patient named Thompson." "No discharge scheduled for this morning. No ambulance pickup arranged." I insisted that I had just completed Thompson's transfer, showing Wilson the signed documentation and describing the ambulance service that had transported the patient. But Wilson couldn't find any record of Thompson in our patient database, no admission history for anyone by that name, and no administrative approval for morning discharge activities. "David, there's no patient Thompson in our system. Never has been. And no ambulance was scheduled for pickup this morning." I checked the transfer documentation more carefully, reading the patient identification information that I had verified before releasing him to ambulance care. The papers clearly stated, Thompson, David, age 34, long-term care transfer to Millbrook facility. But my name was David Martinez, not David Thompson. Yet the patient identification matched my physical description, my age and personal details that corresponded to my own background rather than any psychiatric patient I had apparently transported Someone whose name was similar to mine but whose identity information matched my own personal characteristics. Wilson, check the documentation again. The patient name is Thompson, but the personal details match my information. Wilson examined the transfer papers carefully. David, this paperwork shows your personal information, your age, your physical description, your background details. But the name is listed as Thompson rather than Martinez. I tried to understand how transfer documentation could contain my personal information while showing a different name, perhaps administrative error, clerical confusion, or patient record mix-up that had resulted in incorrect paperwork. But I had clear memories of escorting patient Thompson, conversing with him during transport, and releasing him to ambulance care. The patient had been real, cooperative, and appropriately prepared for discharge. I contacted the ambulance service to verify Thompson's transfer and confirm his arrival at Millbrook facility. Sir, we have no record of any pickup at Riverside Hospital this morning, the dispatcher reported. No ambulance was scheduled, no crew was assigned, no transport occurred. But I had personally witnessed the ambulance, spoken with the EMTs, and signed documentation. Verifying Thompson's release to their care, I checked with Millbrook facility to confirm Thompson's admission and ensure he had arrived safely for continued treatment. We're not expecting any patient named Thompson, the Millbrook intake coordinator said. No admission scheduled, no bed reserved, no arrangements for psychiatric care transfer. Thompson had apparently been transported by an ambulance that wasn't scheduled to a facility that wasn't expecting him, despite comprehensive documentation that had appeared authentic during the transfer process. Over the following days, I found myself thinking frequently about patient Thompson and wondering whether his discharge had been completed successfully. But I couldn't locate any information about his current location or continued care arrangements. On March 15th, exactly 1 week after Thompson's transfer, I received a disturbing phone call at home. "Is this David Martinez?" asked a calm, familiar voice. "Yes, this is David Martinez. This is David Thompson. I wanted to thank you for your professional assistance with my transfer last week." The voice was identical to the patient I had escorted to the ambulance, but he was calling me by my correct name while identifying himself with the name from the transfer documentation. "Where are you calling from, Mr. Thompson?" "I'm at my destination. The transfer was completed successfully thanks to your assistance." "Are you at Millbrook facility?" "I'm where I needed to be. The long-term care arrangements are working well." The conversation was brief and cordial, but it confirmed that Thompson had reached his intended destination despite the apparent lack of official records or facility acknowledgement of his transfer. I never encountered patient Thompson again during my remaining time at Riverside, but I kept the transfer documentation as evidence of discharge procedures that operate beyond normal administrative systems. Sometimes, I wonder whether the transfer was successful because it represented a different kind of patient discharge, one that required personal assistance from staff members who understood their professional responsibilities even when official records couldn't document the full scope of services being provided. Some patient transfers, I learned, transcend normal hospital procedures, requiring professional dedication that extends beyond standard documentation while ensuring appropriate care transitions for individuals whose needs exceed typical administrative capabilities. My name is Michael Torres, and for 8 years I worked as security technician at Westfield Psychiatric Hospital. My responsibilities included monitoring surveillance equipment, reviewing recorded footage, and maintaining the digital security systems that provided comprehensive coverage of hospital areas requiring observation for safety and regulatory compliance. Our surveillance system consisted of 47 cameras positioned throughout the facility, patient wards, common areas, corridors, and entrance points. The cameras recorded continuously, with digital files stored on secure servers that allowed review of incidents, verification of staff activities, and documentation of any unusual events requiring administrative attention. Routine surveillance review involved examining footage from the previous 24-hour period, looking for safety violations, patient incidents, or security breaches that required follow-up investigation. Standard institutional security work that I'd performed thousands of times without encountering unusual phenomena. For 7 years, surveillance footage showed predictable hospital activities, patients moving through corridors, staff conducting routine duties, and the normal patterns of institutional life that occurred during different shifts and operational periods. But in November 2020, I began noticing anomalies in the recorded footage that challenged my understanding of both surveillance technology and the basic principles of visual documentation. The anomalies initially appeared minor. Patients who seemed to be in 2 different locations simultaneously, staff members whose movements didn't align with normal walking patterns, and timing discrepancies that suggested activities were occurring faster or slower than normal speed. I assumed these were technical glitches related to digital compression, camera synchronization, or server processing issues that occasionally affect surveillance systems. Complex digital equipment can exhibit various types of recording artifacts that create visual anomalies without indicating actual security concerns. But the anomalies became more frequent and more pronounced, developing into clear documentation of impossible activities that violated basic principles of human movement and spatial limitations. On November 15th, while reviewing Ward 7 footage from the previous evening, I observed something that made me examine the recording frame by frame. Patient Morrison appearing simultaneously in 2 different locations. At 9:47 p.m., Morrison was clearly visible in his room, sitting on his bed and reading. But at the same timestamp, Morrison was also visible in the day room, participating in a group activity with other patients. I checked the camera timestamps and digital signatures. Both recordings were authentic, both showed the correct time, and both documented Morrison's activities during the same moment. But Morrison couldn't physically be in 2 locations simultaneously. I examined additional footage from the same evening, looking for technical explanations for the impossible dual presence. But instead of finding explanations, I discovered more patients exhibiting similar phenomena. Individuals appearing in multiple locations, conducting different activities and somehow existing in several hospital areas at once. Patient Morgan, simultaneously in room 314, sleeping and corridor, walking with staff. Patient Williams, room 307, watching television, and day room, playing cards. Patient Davis, room 322, medication time, and therapy room, group session. Each patient was documented performing multiple activities in different locations during identical timestamps, suggesting that surveillance cameras were recording impossible patterns of human presence and movement. I consulted with IT support about possible technical problems with the surveillance system that might create artifacts resembling multiple presence phenomena. Mr. Torres, the system is functioning normally, the technician reported after comprehensive diagnostic testing. No technical issues, no synchronization problems, no digital artifacts that would create dual imaging. But the impossible footage continued accumulating. Patients appearing in multiple locations, staff members conducting simultaneous duties in different hospital areas, and activities that exceeded normal human capabilities for movement and presence. On December 3rd, I made a discovery that troubled me more than the patient anomalies. Footage showing my own impossible activities. The recording showed me entering Ward 5 at 2:30 a.m., conducting surveillance equipment checks and reviewing camera positions throughout the ward. But I had never visited Ward 5 during that shift, had no assigned duties in that area, and had been continuously present in the security office throughout the recorded time frame. Yet the footage clearly showed me performing professional duties in an area I hadn't visited, using my standard work methods and demonstrating familiarity with Ward 5's layout and equipment. I checked my work logs and duty assignments. No record of Ward 5 activities, no authorized access to that area, and no explanation for my appearance in surveillance footage from locations where I hadn't been present. But the recording was authentic, showing my face clearly, documenting my characteristic work patterns, and capturing professional activities that corresponded to my normal surveillance duties. I began reviewing additional footage, looking for other instances where I might appear in locations I hadn't visited or conducting. Duties I hadn't performed found extensive documentation of my presence throughout the hospital during times when I had been continuously stationed in the security office, reviewing equipment in various wards, conducting security checks in multiple areas, and performing maintenance tasks that I had no memory of completing. The surveillance system was somehow recording my activities in areas where I wasn't present, documenting professional duties I wasn't performing, and creating visual evidence of work that exceeded my normal capabilities and assigned responsibilities. On December 20th, while reviewing particularly complex footage that showed multiple versions of myself working simultaneously throughout the hospital, I made a discovery that challenged my understanding of both surveillance technology and personal identity. Frame-by-frame analysis of my movement patterns revealed something disturbing. The multiple versions of myself weren't identical. They showed subtle differences in posture, facial expression, and work methodology that suggested different individuals rather than technical artifacts of the same person. Each version of myself was conducting surveillance duties with slightly different professional approaches, as if multiple security technicians who resembled me were working throughout the hospital during periods when I was officially alone in the security office. But all versions demonstrated comprehensive knowledge of hospital security procedures, familiarity with surveillance equipment, and professional competence that matched my own training and experience. I realized that the surveillance system was documenting security activities that transcended normal staffing limitations, showing comprehensive hospital coverage that exceeded what any single technician could provide. During standard shift duties, the multiple versions of myself were apparently ensuring complete security coverage throughout the facility, monitoring areas and equipment that required attention beyond normal surveillance protocols. On January 8, 2021, while reviewing footage from the previous evening, I found something that made my hands shake. Recording of my security office that showed the area empty during times when I was certain I had been present. The footage showed my chair rolling back from the surveillance monitors, as if I had just stood up and left the area. But the chair continued rolling for several seconds, suggesting sudden departure rather than normal movement away from the workstation. Yet I had no memory of leaving the security office during the recorded time frame, and I was certain I had been continuously present throughout the evening shift. The surveillance system was apparently documenting my absence from duties I remembered performing, while simultaneously recording my presence in areas I had never visited. I submitted my resignation the following week, citing health concerns that made continued work with surveillance equipment inadvisable. But I kept copies of the impossible footage as evidence of security systems that operate according to principles beyond normal technological limitations, providing comprehensive monitoring through surveillance capabilities that transcend standard staffing and equipment constraints. Some surveillance work, I learned, requires security coverage that extends beyond normal human presence, ensuring complete facility monitoring through professional dedication that operates independently of standard employment limitations and technological specifications.